Hello, everyone. Welcome again to another episode of the Art of Med School. This time, we're going to talk about the approach to abdominal pain. And this is something that is incredibly frustrating at times because often, like if you got an ER shift, you're going to see it so frequently. It's one of the most common complaints. And a vast majority of the time, it is absolutely nothing, but sometimes it can mean deadliness. I've definitely been caught in that trap where I had this, little old lady that came in for like 2 weeks of just kind of generalized belly pain, not really descript, a little bit of nausea, some vomiting. It's just kind of like, it's fine. But my kids told me I had to come in, one of those kind of old ladies. Turned out to be a triple A that was leaking. So big deal, right? All right, the approach to abdominal pain today. We are going to go through that. So first, let's talk about the different types of pain. So, especially when we're talking about abdominal pain, there's essentially four types: the parietal pain, the visceral pain, the referred pain, and the abdominal wall pain. Parietal pain, that's the actual inflammation of the peritoneum. So, if you remember that all of your guts sit inside a sac, and that sac is called the peritoneum. And when that has different innervation, right? So, when that gets inflamed, uh, it inflames like that whole area. That we're still kind of learning to understand what exactly the job of the peritoneum is, aside from just keeping everything in place. But there's this idea that it can contract and help to wall off infections. So, but since it is a sac, every time that you change the tension in the peritoneum, you're going to get pain, right? So this tends to be sharp. It's well localized. Your body can tell where things are through the peritoneum. And this is typically inflammation from like irritants, right? So like you're spilling your gastric juices, like a ruptured peptic ulcer or something like that. It could be fecal material if you've got you're dumping your bowels out for some reason. Blood, bile, enzymes, all these can cause peritoneal inflammation, which is super painful. Visceral pain, on the other hand, is localized based on the embryologic origin. So again, going back, if you can remember your embryology, that there's essentially three different parts of the gut. There's the foregut, the midgut, and the hindgut, right? So you're going, the foregut is going to localize to the epigastric area, the midgut to the periumbilical, and the hindgut to the suprapubic. So, for instance, I think the example that is the easiest to understand would be appendicitis. Appendicitis starts; it's part of the midgut, right? So the pain starts in the periumbilical area because your body doesn't know any better. It can't localize that; it just knows that it's in pain. So it starts periumbilical, and then as that appendix that inflammation spreads then to the peritoneum, then it's able to localize because it's not that it's feeling the appendix better, it's that it's feeling the inflammation of the peritoneum. And so then you're having that right lower quadrant pain because that actual peritoneum is inflamed at that point. So that's why the pain in appendicitis has a tendency to migrate, that it starts periumbilical then migrates to the right lower quadrant. It's not that the pain itself is actually moving, it's really just how we're interpreting that pain. So visceral pain tends to be constant. It tends to be colicky, and then again, it focalizes when the inflammation hits the peritoneum. Examples here are like ischemia, right? So severe and diffuse pain, you get it all over. And if you've got someone with like a truly ischemic bowel, you just barely touch on their belly and they're about swinging on you. Obstructions, so small bowel obstruction, gallbladder can be obstructed. Your kidneys can be obstructed. Kidneys are super colicky, and so colicky is that idea that there's like um as that peristalsis happens around the stone, as that movement happens, then you're feeling more of that pain. Also inflammation like appendicitis, IBS, hepatitis, but again not very easy to localize because we don't innervate in that way. So then there's also referred pain, so overlapping supply by neural segment, and then abdominal wall pain, which is like the actual muscles, right? So constant, it's aching, it's like a muscle spasm. It can involve other groups. So let's talk about the approach though. So you got someone coming into your clinic or to your ER and they're saying, "Hey, I got abdominal pain. What do you need to think about and where do you need to go with this?" So again, I'm an ER resident, so I focused on a lot of the things of like not necessarily the most likely, but the worst case scenario. So for us, the can't miss diagnosis, you have to think about this every time. Would be that triple A, the dissection. You can't miss an appendicitis, so you have to think about that every time. DKA or diabetic ketoacidosis, that's another thing you have to think about this every time. Ectopic pregnancy, an incarcerated hernia, an ovarian or testicular torsion, and then also non-abdominal things like infarction or ischemia. Well, that's the bowel, but myocardial infarction. In fact, uh, even to add to this, it's not a can't miss diagnosis, but just last night I had someone who came in with belly pain, ended up being a pneumonia. So good history. If you're internal medicine, you're going to take a really, really long, thorough history. If you're ER, you're going to get just enough because that's just how we tend to do things differently. But really characterize that pain, right? So what's the onset? Has it changed since the beginning of the pain? Does anything provoke it or make it better, or sorry, make it worse? Can you describe the type of pain? Like, is it a sharp pain, cramping pain, dull pain, burning pain? And this is what I always struggle with is how to get people to help me understand what that pain feels like without putting words into their mouth. Radiation, does it go anywhere? Does it go to the back? Does it go to the groin? Does it go across the stomach? Severity on a scale of 1 to 10, how bad is it? This one, all right, honestly, it's part of the mnemonic. Everyone always talks about it. You can't not have it, especially for like board type stuff. But I honestly, I find severity to be just not helpful. You'll have someone laying in bed on their phone and they're like, "Oh yeah, it's a 15 out of 10." Like, no, no, it's not. I'm sorry. Uh, Time. How long has it been going on? And then, of course, relation to food is a good one to help you. Again, and this is another one. I document it, I ask it, but I don't always trust it. Um, Someone can just there's just too much happenstance as far as relation to food for me to really be comfortable with this guiding any kind of decision making for me. Other things that are not pain related, anorexia. Have you lost your appetite? Are you having nausea and vomiting? Can you characterize the vomit? Is it bile? Is it red? Is there changes in color? Can you quantify? People will say things like, "Oh, I've been vomiting all day." Like, okay, but how many times have you actually gone to the bathroom to vomit? Like, well, three. Like, okay, that's not really vomiting all day, but any respiratory symptoms, again, that abdominal pain that turned out to be pneumonia, stool changes, urinary changes. That bladder is sitting right there, right? Also, surgical history. What is surgical history important for? Do, do you have your appendix? Do you have your gallbladder? And then any previous operations, right? Any other previous operations, like have they had a hysterectomy? Because then you're thinking about if maybe they don't have their ovaries anymore, or if they've had a number of abdominal surgeries, then they're at a higher risk of adhesions. And then any medications, right? So I had someone who came in for abdominal pain. He was a elderly gentleman in his early 70s or something like that, and turned out that he had a back surgery done like 2 months prior and was on chronic opioids after that. First time he'd ever used opioids in his life, um, and then that helped guide my treatment plan or my thought process. So, what are some of the classic complaints? Thinking about things like, and this is pretty textbook stuff, right? So, diffuse severe colicky pain and nausea. You're thinking about a bowel obstruction. Pain out of proportion to exam, mesenteric ischemia. Epigastric pain that radiates to back with nausea, vomiting, pancreatitis. Shoulder pain, you're thinking about things that are going to be up near that diaphragm because that's referred pain. So, like spleen, hepatitis, is there some free fluid? You should do a fast on these. Pain with syncope could be a triple A, it could be an ectopic. And then pain with focal neurologic deficit, definitely think about a dissection. This one is actually come up quite a bit for me. Maybe not quite a bit, but enough where I happened to be sitting next to my attending, and a med student had gone and seen a young man. He was actually just in his late 20s. Um, and she was like, "Yeah, I'm gonna go see this abdominal pain." We're like, "All right, he's 20 something year old with abdominal pain. Like, that's cool." And she comes back. She's like, "Yeah, he kind of looks sick. He had abdominal pain that started this morning, and blah blah blah. And oh yeah, he can't feel his left foot." And I was like, "What?" I jump up and I run over, and sure enough, he's hypertensive. We don't even get the imaging right away because it's a long story, but without even ordering the imaging, we just went ahead and started on the esmolol, and sure enough, he was a type A and B dissection. They'll catch you. All right, so then your physical exam. Do your general appearance, right? So signs of hypovolemia, look for the hypotension, the tachycardia, the tachypnea. These are all late signs. You might find signs of dehydration first. I'm a big fan of looking at people's tongues. I find that to be very easy to get a gauge of their mucous membranes, how shriveled is their tongue. It also gives me a chance to look for like fasciculations or something like that if I'm thinking about any kind of like alcohol abuse, which is pretty high in my population that I work with. I like to look in their eyes. I like to look for signs of pallor, especially like the conjunctival pallor. We get a lot of GI bleeds, and that's a good place to get evidence right away. Do they have fever? Is this an infectious process? Is there the icterus, the jaundice? She's got signs of yellowing that you're thinking about some kind of obstruction or something causing an elevation of the bilirubins. Distal pulses. All right. This one I'm not always good at is checking your pedal pulses, checking your radial pulses. Is there discrepancy? Is there some kind of vascular pathology that would be causing a change in the pulses from one side to the other, or from the top to the bottom? So then in the abdomen, 100% you got to look at the skin. And where I train, sometimes we are super super busy. We are actually ridiculously busy a lot of the times, and these abdominal pains get downgraded in the level of care, the not level of care, the level of urgency, and often they get put in a room. They're not in a gown, they're not properly placed, and so you like go to see this abdominal pain and they're all shirt and dressed, and like you have to look at the skin. What if there's bruising? What if there's caput medusa? What if there's an overlying rash? uh, 100% look at the skin. Look at the curve of the stomach. Is it normal? Is it distended? Is it scaphoid? Right? Do you hear bowel sounds? Okay, I do not do bowel sounds. I'm gonna be honest. I know I probably should, but when you're in a busy ER, this one takes a while to do, and you cannot hear very well. Check for a mass. This came up just last night. I had a patient with epigastric pain, and I'm like, all right, so they were relatively young, probably pancreatitis. Maybe they hit it a little hard over the weekend, whatever. And pushed around, check on the epigastric area where pain is. Sure enough, there's a mass. It was a hernia. There was no overlying skin changes because I looked at the skin. But all I ended up having to do was reduce it, and she got to go home. So, and then when I push to find out where it hurts, I start everywhere else except for where it hurts, and then I work my way into that direction. And depending on my level of suspicion, I will talk to them at the same time. Sometimes people's abdomens are tender because they expect them to be, as opposed to them actually being tender. So a little bit of distraction can really help you determine if they are having proper tenderness, or if they are more just worried. So adjuncts that you would consider. So if you got a right upper quadrant, add the Murphy sign, right? Have them take a big breath, kind of hook them, and then have them let it out. See if you can't touch that gallbladder and see if it hurts. If it's right lower quadrant, you're thinking about appendicitis, do your McDermid's, your operator psoas. It's low specificity or low sensitivity. I like to do it anyway. It just helps me round out the chart, and gives me a better idea. There's not a lot of really great evidence on that. Consider if you need to add a rectal or a pelvic exam. I hate to say it, but I've added a lot of rectals to my exams, and you know what? I get a lot of positive hemo occult, and I know again the data on that is not great, um, but I do end up starting quite a bit of protonics on people because they have blood in their stool. Pelvic exam, it's questionable, right? Again, kind of mixed data. This really seems to depend on practice patterns and who you're talking to. Flank pain, absolutely tap on their kidneys, get that CVA tenderness. And honestly, this is something that I do on a lot of patients is hit their back and see what happens. And then suprapubic. So if they have suprapubic pain, and especially if they're tender there, and I push on, that's part of my abdominal pain, like pushing. I hit every quadrant, epigastric, the paraumbilical, and then I go a little bit further south and make sure to push on that bladder. Are they tender in that bladder? Do you need to add the bladder scan, or do you need to add the pelvic exam? And consider the pelvic exam for the lower quadrants too, because then you're thinking torsion, right, or ectopic or whatever. Okay, what lab studies? So CBC, CMP, get your electrolytes. You want your liver functions to lipase. I get lipase on pretty much everyone. Urinalysis. So this is one that I've been kind of rethinking as far as the utility of my urinalysis. I might be thinking about it for like signs of dehydration, but consider whether or not they're actually having urinary symptoms. There's a big push right now on not treating positive urine, uh, like your UAs that are positive for bacteria or signs of infection if they are not having symptoms, right? So we'll talk about that more in another one, but make sure your urinalysis actually has applicability and utility. Get a beta HCG, especially if they're a woman. Maybe you can lay off if they're a guy. Think about a lactate. Are you thinking about some kind of ischemia? This is a good way to get a sign of ischemia. On almost anyone that has epigastric pain, I will get a trope, uh, even if it's just one. On anyone old with just general abdominal pain, nausea, or vomiting, I will get a trope. PTINR, PTT, um, again, if it's applicable, just at least think about it. Adjunct studies, get that EKG for anything epigastric. I am a huge fan of just making sure that I don't miss something silly, because guess what? I did. Upright chest X-ray. Even if I'm getting a CAT scan, I will often order an upright chest X-ray, kind of depending on the quality of the pain or the severity of the pain. And the reason for that is if I get a CAT scan and we're busy, it is going to be a hot minute before they get down to that CAT scan and they get their exam. Upright chest X-ray, just a single view, gets done in the room. They wheel that thing right over. They pop a picture. You take a look. Free air, no free air. Right there. And I again, I've only been a resident for a year and a half, but already I've had someone in line to get a CAT scan. He was probably an hour or more out. I got the chest X-ray in the meantime, and guess what? Sure enough, free air. He ended up going to the OR without even ever seeing a scanner. Uh, Also, pneumonia, right? Pneumonia can be a thing. So think about a formal ultrasound, like a transvaginal. Again, same thing here. If I've got a pregnant patient and I'm worried about some kind of like genital urinary thing that I need to think about the baby, I'll often throw that bedside on and just check on the baby real quick. And if everything looks good, cool. If not, like, then that might change your focus here. So, uh, and oh God, that's one of the conversations I have a hard time with. There are some conversations, it is easier for me to tell someone's family that their loved one has died than it is for me to tell a pregnant lady that she's lost a fetus. I've yet to figure out how to have that one well. Anyway, CAT scan with IV. There's pretty much no reason to not get contrast. I know there's some of the older docs who will prefer it without if they're just concerned for a kidney stone, because of the idea that the contrast will hide the kidney stone. If it's big enough to see with contrast, or if it's small enough to not see with contrast, then it's small enough that you probably don't really care anyway, right? And then a POCUS. So just doing that bedside. You can check for free fluid. You can check. You can do a quick retroperitoneal kind of ultrasound. Look for like hydronephrosis. You can check a gallbladder. You can do an aortic one. So this can give you a lot of information really quick at the bedside to either reassure you or like hustle this person up the ladder if they need to. As far as treatment structure, consider if you need to do an NG or an OG if you need to decompress them if there's some kind of obstruction. Give them some fluids because they're probably losing fluids. You're probably gonna have to replete some electrolytes. Antiemetics, right? Give them some Zofran if they need it. Pain control. This is sometimes we get, especially in the ER, we get really really excited about the pathology or like being just honestly busy. We order all the tests and then we forget about things like pain control. And then the rest, of course, being pathology specific. All right, so that's the approach to abdominal pain. Again, some really, really generic. The idea being just like thinking about how we need to think. Here are my references. Thank you very much for your time. We'll be back with some more lectures.